listed. There's a lot of other stuff under settings, but I'll let you play with that on your own time. Under existing patients, so I know each unit only has one monitor. If you are treating multiple patients, set them up with the pads, you can bounce from patient to patient to patient. Their ID is stored in here. It stores 1,000 hours worth of patient info. Oldest patient gets kicked out first. Simply hook them up, look them up, go. I'm going to do new patient. It's going to ask for ID. I say use the medical record number. Has there been any discussion of this thing charting for you guys here, like connectivity wise? What system do y'all chart with?
Oh, Lord. McKesson. We're doing an upgrade July 25th.
To
McKesson.
oh, okay.
Is it
All right.
1965?
I don't know that we're charting that one.
Said something this morning, I was like, really? That much?
I'm going to throw some random idea. Just don't use something like a room number. It's in here for 1,000 hours once you put it in. It's going to ask you for age. It's going to ask you for weight in kigs or pounds. Then it's going to ask you for height in centimeters or inches. Then it's going to ask you for gender. This is becoming a more common question these days. Use what they were born as, not what they're trying to become. Okay.
That's also questionable, apparently.
Well, all of our correlation data is based on gender-specific circulatory systems, so we need to try to be as true as we can. So at that point, finish is our only option. It lets you review all the data you just put in. If you agree with all of it, go ahead and start session. Everything is green, lets me know I am connected. If one side is disconnected, it will flash red at you. You can spin him around if you want to. It doesn't mean a thing in the world. I'm going to hit start session, and we are now monitoring. The first 2 minutes this thing is turned on, it does its own calibration. White bar at the top lets us know that it's running. You don't have to level anything, you don't have to zero anything. Once you verify that you have these 2 EKG lines and this stroke volume waveform, the screen's not going to be much use to you. So I say swipe, just like on your iPhone or your iPad, swipe up, and it allows you to change screens. Okay? Now, you see cardiac index, cardiac output, stroke volume index, TPR, TPRI. These first 4 values here, stroke volume, cardiac index, cardiac output, and the indexes, they're going to auto-populate. Every minute, you don't have to do a thing in the world. There is a 30-second mode on this thing if for some reason you want to see your numbers more rapidly, but I think usually 1 minute is sufficient. The only way you're going to get TPR or TPRI is if you either A, run the blood pressure cuff that comes with the monitor, but you probably already have one on your patient. I don't know why you'd want to. The next best option is to tap the box, enter map, whatever your last blood pressure read, or if you're using an art line, whatever it's currently reading, plug the map in, hit enter. At the top of the minute, when you get these measurements, it will calculate your TPR. In less than 10 seconds. And there we go. So now you've got contractility, preload, afterload. Those 4 areas we just talked about. Y'all now see the importance of those 3 areas? I hope that lecture had some impact. All right, I'm going to take you to the next screen. This is where our results are going to pop up for the dynamic assessments we're going to talk about in a second. Another swipe up takes us to a flow sheet. Minute by minute, it'll fill these lines in with data. Once it fills that page in, it'll make a new one out next to it. You simply swipe side to side to review. Swipe up one more time, and now I have a trend for you with your current data here on the side. If you want to, just because you can zoom into this, and you can zoom back out. One more swipe brings you full circle, so you can't get into anything you can't get out of. A little bit about the buttons on the bottom. Session controls. I've got pause, stop, and recalibrate. Remember I said these things cannot go to MRI. So if you're going to go to the scanner and you want to come back and continue monitoring, I encourage you to pause this monitor. It doesn't hurt anything if you don't, but that flow sheet I just showed you, it fills that in with a whole bunch of red dashes. And so if you're in the scanner for an hour, you've got to come back and swipe through all that nonsense to get back to your last set of data. Under stop, be careful about stop. Stop does the exact same thing as exit. If you get in a hurry, and I know we do, if you hit stop, it's going to give you a second chance. It's going to say, are you sure? If you say yes, it's going to take all the data you've collected, put it in a file by itself, and you have to start a whole new trend. There's no way to link that up. Under recalibrate, treat this thing just like an A-line. If you didn't believe your A-line, you would zero it and level it. Same thing here. If you don't believe your numbers, they changed and clinically there's no explanation for it, be sure you have good skin contact with your sensors and then recalibrate this monitor. Okay? I would also encourage you, if you're starting your shift, just like you would zero out all your lines at the beginning of shift, go ahead and recalibrate this monitor. You don't know what happened in the last 12 hours before you got here, so it's nice to know that your numbers are right. Under user data entry, you saw how I hit TPR to enter the map. You can also do user data entry and enter the map that way. You'll also see enter hemoglobin, enter SpO2. If you plug in those two values, it will give you DO2I. Do you guys follow that? The oxygen delivery index. I know some post-op heart docs like to see it. I just don't want you thinking that this thing's going to measure your hemoglobin and your SpO2 for you. Okay? Some people see those buttons and, oh, it's going to read that too. No. No, it will not. Under events, we have all kinds of preloaded events that you can chart in this thing, and it just makes notations on the flow sheet for you. I'll let you all review that on your own time. I want to talk about these dynamic assessments now. To do that, I want to go to this screen. So we've got the passive leg raise and the fluid bolus challenge. We've already talked about both of them. To do either one of those assessments on this monitor, you have to first have a 3-minute baseline where your stroke volume index does not vary more than 2 points. Okay? I'm checking to see, with a flat baseline stroke volume, can I increase by 10% or more? If my baseline looks like this, I cannot do a good comparison to that. When you are doing the baseline for the passive leg raise, your patient has to be sitting up at a 45-degree angle. Their legs have to be straight. Their SCDs need to be turned off. Okay? I need the blood to pool in the legs. If it's squeezing out of the legs, I've got no bolus. I need them flat. I don't need them elevated. I also would encourage you to stop any non-essential fluids for this. Maintenance volumes, IV piggybacks, things like that. Don't stop your pressors, please. A couple of reasons. A, your patient may die. B, I need to know, do I need to do something extra on top of what I'm already doing? Okay? This is a calm procedure. You don't need family and they're stroking the patient, telling them they're beautiful. You don't need to be sticking them with needles, and you don't need x-ray shoving plates under them, because I need a good, calm, flat baseline. If they are being stimulated and their stroke volume is falsely elevated, you're not going to get a 10% improvement. There's no way to go up. So, calm. All right. Oh, I've got my 3 minutes. Okay. Who wants to be my helper? I can't lay on the floor and do this at the same time. I nominate you. You're closest to me. All right. So, dynamic assessments. Pick PLR for me. There we go. It's going to ask you, do you want to start immediately from the challenge stage? As long as you came to this screen and you verified the last 3 minutes for yourself, you can do that. If you say no here, it's going to send you into a 3-minute baseline acquisition you don't have to do. It's a waste of your time. So pick yes, and now it's going to prompt you. It wants you to take me from sitting at 45 degrees to lay my head flat, and then I know you'll have the big inflatable cushion. Okay, there's a big, have you seen the cushion?
No.
It's a big purple wedge. Looks like a big air mattress. And it holds the legs at 45 degrees for you so you don't have to.
I think I'm
Okay, so this is going to be my cushion. As soon as those legs go up, you need to be ready to hit next on the monitor, because the blood's going to start flowing fast. So go ahead. And go down. There we go. Now we've got a 3-minute clock that's going to start at 3 minutes and count down. Most of your patients are going to see their response within the first minute and a half. So if you have a patient who's agitated, who absolutely will not stay flat for 3 minutes, you can watch the screen for yourself. And if you get a 10% improvement within that first minute, you know your answer. Okay? You don't have to wait the full 3 minutes. Now, what are some things that are going to prohibit me from doing this kind of assessment to a patient? We already talked about one. You got to have legs.
Yeah, legs.
And you got to have 2 legs. A unilateral BKA does not count, because the majority of the blood is coming from the calf muscles. If you chop off one of my calves, you just cut off half my volume. On that same note, if you have some frail little old lady and her legs are that big around,
You're moving.
I know. I'm still gonna be fluid responsive. Watch, because I haven't drank enough this morning. she doesn't have adequate capacity to bolus with. So you're not going to get a good test.
Or the skinny ladies,
Skinny legs, yep.
or how skinny? What,
It is subjective. So if you're not sure, you can raise their legs.
okay,
If you get a positive response, she is fluid responsive. If you get a questionable result like 9.5% or 9.6%, I would probably encourage you to use the bolus challenge as a tiebreaker. All right, what else? I'm laying on the floor. Come on, guys. DVTs,
so yeah,
non-fluid mass sitting in the middle of, test complete.
It says it's unable to perform the assessment.
Oh, I'm moving too much.
Do it again.
Hit restart. All right, let me be still. What's it saying?
Just make sure the pillows are removed, SCDs are off, and that.
Oh, it's wanting to do a baseline on me. You're right. I should've
Yes, the
been-
30-minute baseline.
Yeah, it's trying to make do another baseline on me. Oh well.
Probably feels so much better.
Oh, my head is pounding. Okay, anyway. I'm gonna have it run. That was moving too much. DVTs, non-fluid mass sitting in the middle of my reservoir. I can't get it to the right, to the left side of the heart to actually test it, but I don't want to go into the heart, period. Do you guys ever get pregnant patients in here?
yeah, we do occasionally.
Okay.
Yeah, we do.
I know pregnant moms get septic sometimes too. If that baby is late term gestation, 7, 8, 9 months, if you lay that mama flat and baby falls back on that vena cava, it's going to inhibit that return flow from the legs. It's not going to work.
Absolutely.
Abdominal compartment syndrome, abdominal hypertension will do the exact same thing as that baby. Okay? I know you guys get cirrhosis patients. Portal hypertension, can't get the blood through the portal vein in the liver quick enough. Respiratory distress, the patient's not going to lay there for 3 minutes to tolerate that.
No.
Now, those are one of those ones, if you can get them to lay there for that minute and a half, semi-calmly, you may be able to get a result out of it. Okay? But again, it's subjective, and I'll let you use your clinical judgment on that one. Your psych patient's not going to lay flat for 3 minutes. It's not going to happen. And then, do y'all ever get head injuries? Increased ICPs. You lay them flat for 3 minutes, you'll stroke them out. But for all other patients, especially those CHFers, those renal patients, this is a great test. I can assess. If it turns out volume's not the answer, sit them back up. No harm, no foul. I'm going to go ahead and let this thing run. I'm actually going to show you the curve here in a second. I'm not laying back on the floor. So now let's talk about the bolus challenge. I don't care what kind of fluid you give, as long as you can give 250 cc's within 5 minutes or 500 cc's within 10 minutes. So 999 on the pump, I'm not going to get this done. That's 250 in 15 minutes. That's too slow. So we're talking, it's going to be pressure bagged in. I had a physician do it with albumin and 60 cc syringes one time. Do you have an 11-1 trauma infuser?
We have,
Okay.
for that blood, is that, yeah, that's one we just bought.
So that will do it too.
What?
That'll push that bolus in quick enough. I don't care what position the patient is in for this baseline, as long as they will stay there for the 3-minute baseline and the duration of the infusion. This is like a math equation. I only need one thing changing at a time. That needs to be fluid, not position. Okay? When you are priming the tubing for this bolus, please leave that drip chamber about half empty. I have nurses that go in there and squeeze that thing full to the top, and then when I open the roller clamp, I've got no idea if it's even flowing.
Right.
Also going to have good access. 24 in the pinky's not going to make this happen. Same thing. Come to this screen. Look at the last 3 minutes for yourself. If you like, yay, baseline done. All right, so we're going to pretend like I'm doing the bolus now. Just like when I laid flat and the legs went up in the air and we hit next, as soon as you open that roller clamp, you need to be ready to hit next on the monitor. Now, with the passive leg raise, the clock starts at 3 and counts down. With the bolus challenge, it starts at 0 and counts up. You have to tell the monitor when the volume's done, or you'll never get your test results. Okay? Let's say I'm doing the 250, It has to go in within 5. Let's say I get it in within 3 minutes. I'm going to continue to let the test run for a little while. Why would I want to do that? That's it. I got to get it through the right heart, through the lungs, into the left side where it actually see that improved stretch and when it moves forward. Okay? What a lot of my nurses will do is they'll sit here and they'll look at the stroke volume index. Every minute that it climbs, they let the clock run. But that first minute where it plateaus off or drops down, then they come down here to dynamic assessments. The only option is in bolus at that point. Right now it says NPLR, obviously, because we're running through that one. It doesn't matter how long you wait to stop the test. It's always going to take the highest delta while the clock was running. So if you saw your volume go in and suddenly you got called away, that's okay. You know the volume went in time. You can come back and stop the test and get the calculation at any point. I've had some people call me that weren't sure, 45 minutes has gone by and they never calculated anything for them. Go ahead and stop the test. You'll still get your test results. It just took you 45 minutes to get them. Okay? Let's say the patient had no legs, had poor access. That's where the trending comes into play. And I would say come to this screen right here. Just make a note of what time you started your fluid. You could even come in here to events and add the event, and it will notate it for you. Just watch what your stroke volume does. Remember, we're always trying to improve stroke volume. If it's not improving with fluid, we're not doing any good. Okay? How much longer do I got here? Less than a minute. I'm sure most of you have seen the Frank Starling curve that the monitor generates. It also gives you the graph. You can repeat these assessments as many as you need to, and it simply builds a new page every time. So you're not going to lose the results if you do another one. It builds them out next to each other. You simply swipe side to side to review them. Okay? What have I got here? 30 seconds. 10% or greater increase. Do not equate a larger percentage change to more fluid. Okay? I can't say that somebody that's 15% fluid responsive needs less fluid than somebody that was 30% fluid responsive. That doesn't work that way. Okay? We'll also say use your clinical judgment. If your patient has crackly lungs and it sounds like they have fluid on the lungs, they may still be fluid responsive. Don't give them fluid. You need to channel it into the right areas. Okay? Fluid responsive means intravascularly dry. It doesn't mean total body water dry. All right, that was terrible. Negative 3.5% change. It's not an adequate test. Please do not give me fluid if I am a sick patient in your bed. That means I am fluid averse. You sent that volume to my heart. It over-distended the rubber band and broke it. Okay? You have any questions for me? The big